Hello everyone, I'm Part-4, I'm consultant, obstetrician and gynecologist. This is the fourth episode of Deep Dive to CA125. I'm here with my colleague Wessal and I let her to take over.
Hello everyone, my name is Wessal. I'm currently a trainee in the United Kingdom and today we'll be covering CA125 in the context of pregnancy, in ectopic pregnancy, miscarriage and in preeclampsia. Okay, so today we'll be covering CA125 in the context of pregnancy, in ectopic pregnancy, miscarriage and preeclampsia. So in CA125 in pregnancy, we find that there is a rise of CA125 in the first trimester, and in up to 35% of patients, we find that there is a raised CA125. It is thought that this rise of CA125 in the first trimester is attributed to the decidual trophoblast invasion during placentation. And this is very interesting because later on in pregnancy, during second and the third trimester, we see that the CA125 normalized back to below the cutoff levels of 35 units per milliliter. Because CA125 has been shown to also have an immunomodulatory role. So it's thought that perhaps the raise in CA125 in the first trimester, it could help with fetal development by dampening the maternal immune response against fetal cells.
Also, CA125 has raised in patients with ovarian cancer, and the role of CA125 would be to suppress natural killer cells, and it helps cancer to metastasize, and his immunomodulator action maybe play a role, during pregnancy. And as a result, we know that during the first trimester, we can see the raise in the level of CA125. On the contrary, during implantation, we see the downregulation of CA125 in order to help implantation of the fertilized egg.
So CA125 levels tend to be raised towards term and immediately after birth. And what we find is that the CA125 levels are higher in patients that have delivered vaginally, and it's thought this is due to myometrial contractions resulting in raised CA125. And the levels in patients that have had a vaginal delivery are higher than in patients that have had cesarean sections. However, in patients that had cesarean sections, the levels start to rise in the subsequent 48 hours after the operation. So that the raise in CA125 during birth is attributed to the disintegration of the maternal decidua, where we find high levels of MUC16 or CA125. Okay, so in the context of miscarriage, CA125 is expressed by the fetal membranes and also in the maternal decidua, and we see as I previously mentioned, high levels of CA125 in the first trimester, but also some high levels in patients presenting with first trimester bleeding with impending miscarriage. And in some studies, this has been associated with decidual destruction and trophoblastic separation from the decidual cells. In threatened miscarriage, CA125 has a high predictive value in identifying patients that are likely to continue pregnancy. So at the moment, we use markers such as beta-HCG and progesterone. However, none of them can help us to give a prognosis and see which patients are likely to continue with pregnancy and which are likely to miscarry. However, CA125 can make that distinction. However, we do have a range of cutoff levels from different studies. So the range can be from 50 to 125 milliliters per unit. So it can be very difficult to establish which cutoff level can be used to know what the prognosis is when patients present with first trimester bleeding. Just to explain again, when we talk about the levels of CA125 in the context of miscarriage, The lower the levels of CA125, the more likely they continue with the pregnancy. However, high levels are associated with increased risk of miscarriage. So in terms of CA125 in ectopic pregnancy, there is inconsistent evidence regarding the use of it to distinguish between intrauterine pregnancy and ectopic pregnancy. In a case-controlled study, we found that there is a lower level of CA125 in tubal ectopic pregnancies compared to intrauterine pregnancies. And there is a significantly elevated CA125 in ruptured ectopics. However, other studies show that there is no statistical significance between levels, difference in levels, and this could also be attributed to the fact that CA125 levels could be higher in first trimester pregnancies anyway, even if they're normal. Other studies have showed that perhaps serial measurements of CA125 could perhaps distinguish between the early diagnosis of ruptured tubal ectopic pregnancy. But again, due to the inconsistent level of evidence, it's not something that we can apply in clinical practice. In terms of preeclampsia, the use of CA125 appears to be more promising. So there is high levels of CA125 in preeclampsia, and this reflects the fact that how CA125 is raised with tissue stress and inflammation, and this is what happens in preeclampsia. We have systemic inflammation. CA125 also positively correlates with some of the markers or things that we look for in patients where we suspect preeclampsia, such as high systolic and diastolic blood pressure, increased serum uric acid, and urine protein concentration. And it also correlates negatively with fetal weight and birth weight. Patients with severe preeclampsia have higher levels of CA125 compared to mild preeclampsia. However, this association should be interpreted with caution due to concerns about selection bias. So the thing is that these studies look at specifically patients that have preeclampsia, and there isn't enough randomization to compare to patients that don't have preeclampsia. So some of the cutoff levels that have been suggested for using CA125 in the context of preeclampsia is 50 units per milliliter, and a study by Ozat et al. Has shown that this cutoff has a 93.7% sensitivity and 88% specificity, and a positive predictive value of 91% and a negative predictive value of 90.7%. So it appears to be a very good cutoff level for the use in the context of preeclampsia. However, further studies need to be conducted using these cutoff levels to establish what we should be using in clinical practice.
What we know that is not a standard practice, at least in the UK, to use CA125 as a marker to predict severity of preeclampsia. We are just here to discuss different roles of CA125 in order to really expand our knowledge about this interesting molecule, because most of the time when we talk about CA125 as gynecologists, we associate it automatically with ovarian cancer. The whole point of these deep dive episodes for CA125 just to expand our knowledge in order to find out how CA125 works in physiological process like menstruation, like pregnancy, and also non-cancerous gynecological and non-gynecological encounters.
So to conclude, CA125 levels should be interpreted with caution during the first trimester of pregnancy and also during labour and immediately after delivery. Can be a very useful marker in determining the severity of preeclampsia. However, it's still not used in clinical practice. Further studies need to be conducted in order to identify an appropriate cutoff level to use. And the evidence for CA125 in ectopic pregnancy is inconsistent again. So it shouldn't be used in clinical practice, and clinical correlation should be used. So it's very important to know the different physiological and also pathological conditions where CA125 is raised, because as a trainee, when you see a patient in clinical practice who presents with a raised CA125, it's important to try and interpret the levels in terms of their clinical presentation, and also having a look at the history. For example, as we said, CA125 levels can be raised in the first trimester of pregnancy. So if a patient is presenting with raised CA125 and is pregnant, it's important to try and interpret that result with caution, and also clinically correlate it with the symptoms that the patient is having. Thank you very much for listening to our lectures. I hope that you found them very useful. We will be talking more about CA125 in our next lecture.
Thanks very much.